Good morning. Thank you for this opportunity to present our work on the evolving role of EGD in academic general surgery programs and the possible implications for acute care surgeons. We have nothing to disclose. Several authors have demonstrated that EGD can be safely and effectively performed by general surgeons, and we know that basic endoscopy skills are a requirement of general surgical training. We've observed an increase in the use of EGD for non-elective cases by the general surgeons in our group since the implementation of our surgical hospitalist model in 2005. ACS services across the US vary widely in their scope and staffing, and this hospitalist model is just one type. But these evolving services now care for about 20% of the US inpatient population and account for 25% of total US inpatient costs. We designed this study to understand the role of EGD in the management of non-elective problems by the general surgeons at our urban academic center. The goal is to inform the discussion on the potential role of EGD for health systems developing an ACS program and in evolving acute care surgery fellowships. We performed a retrospective review of non-elective EGDs performed by our general surgery group at a single academic center over a 5-year period. Non-elective cases were defined as those performed for patients who presented to the emergency department, were directly admitted from clinic, transferred from another hospital, or were the result of an inpatient consultation. All procedures were performed in the OR by one of 5 surgeons who routinely take ACS call. Of note, 4 of the 5 surgeons in question are MIS fellowship trained. Outcomes of interest were 30-day complications, including unplanned readmission, urinary tract infection, line infection, superficial site infection, deep space infection, new onset AFib and death, and successful endoscopic management. Procedures were deemed successful if they led to a definitive diagnosis, achieved symptomatic relief, or led to resolution of the clinical problem without requiring other modalities, such as percutaneous, laparoscopic, thoracoscopic, or open surgical interventions. Importantly, endoscopic therapy was considered to be successful even if multiple endoscopic interventions were required. Over the 5-year study period, 495 EGDs were performed in 266 patients. Of these, 129, about 26%, were non-elective. 5 surgeons performed a median 41 cases each, and the median follow-up was 9 months. This is a comparison of patients who underwent non-elective versus elective EGDs. We found that patients who underwent non-elective procedures were significantly younger, had higher ASA classes, and longer hospital lengths of stay. Non-elective cases were also significantly more likely to be performed after 6 p.m. or on weekends. This chart summarizes the types of non-elective interventions performed. The most common non-elective endoscopic procedure was endoscopic dilation with or without stent, followed by diagnostic EGD with or without biopsy. Patients undergoing dilation tended to require more than one procedure, but this was not significantly different from procedure numbers for other types of intervention. Overall, the success rate for endoscopic intervention alone was high. This table shows the range of indications for non-elective EGD. The most common indications were a history of foregut surgery with leak or dysphagia, or esophageal perforation. Other, in this case, includes endoscopic removal of foreign body, management of duodenal fistula following necrotizing pancreatitis, biopsy in patients with autoimmune disease, and diagnostic EGD in patients with gastric volvulus or suspected proximal intussusception. Hospital length of stay, complication rate, and chance of successful endoscopic management all varied significantly by indication. For example, patients managed endoscopically for foregut surgery complicated by a leak required significantly more endoscopic procedures than patients with other indications for non-elective EGD. This group of patients was also significantly less likely to be successfully managed with endoscopic therapy alone. Patients treated endoscopically for esophageal perforation had significantly longer hospital lengths of stay, a median of 22 versus 4 days, and significantly greater 30-day complication rates, 73% versus 24%, than those with other indications. The success rate for endoscopic therapy alone was high across all indications, a median of 88%, but patients treated for leak following foregut surgery were less likely to be successfully treated with endoscopic therapy alone than patients treated for other indications. Several limitations that are worth discussing. The study was designed to understand the evolving scope of non-elective EGD and acute care surgery practice, not to determine whether endoscopy is the optimal means of intervention for a given clinical problem. Also, the study was performed at a tertiary academic center with a high proportion of complex foregut and bariatric patients and effectively no trauma. So these patients were overrepresented in our sample. Of note, 4 of the 5 surgeons studied are MIS fellowship trained, so may have had additional endoscopic experience. And importantly, our group has had excellent support from our GI colleagues. In conclusion, we suggest that there's an evolving role for acute care surgeons with appropriate experience and support to manage patients with urgent or emergent endoscopy. I'd like to thank my mentors listed here, particularly Dr. Matthew Lin and Hobart Harris, and the funding source. Thank you.